we're in chapter 9. Is almost the last. We have one more chapter to follow after this, which is the cardiac valves. But chapter 9 is going to basically discussion on regulation of arterial pressures. The single most important factor about controlling your regulation of your blood pressure is the effects of the sympathetic nervous system on the arterioles. So that's really basically how your systemic circulation is maintaining your blood pressure throughout your life. There's certain people that have certain disease states that basically don't have adequate sympathetic tone, and if they try to get up, basically they fall down. Okay, they fall unconscious or they start having seizures, and it's really a pretty bad way to live. What they do for treatment-wise, and something similar to what we do in a sense, is that they volume load themselves. Okay? If you volume load yourself, then as you get up, it's not that much of a shift in your preload, and you don't get hypotensive. Okay? And the other thing that they'll do is they'll sodium load themselves. So these people are usually put on very high salt diets to maintain intravascular volume. Okay? Which is pretty much what the military does too. When you look about dehydration, they give this to the actual military personnel salt tabs. Actually, salt tabs are very dangerous, but they do help keep intravascular volume inside you. Okay? But still, most of us are operating under, especially if you live in Florida, in a dehydrated state, believe it or not. All of you in here, even though you feel like you've been adequately hydrated, are pretty much in a dehydrated state. Okay? The reason I'm telling you that is because if you look at the number of kidney stones we have here, it's one of the highest per capita in the United States. Okay? Simply because we're chronically dehydrated here. We also know this to be true in clinical when you work in OB. If you work in OB up in Chicago, where I used to work before, you never had to volume load people. So sometimes you'll read in the literature that they'll tell you, well, we don't volume load our patients. There's no reason to volume load them. It makes no clinical sense to do that. And says, well, the answer is regional. If you're living up in an area where it has 10 or 15% humidity and you're not losing a lot in an air-conditioned environment, a cold environment, it's fine. But here in Florida where it's very hot and very high humidity, you don't realize that you're sweating sometimes, or you do feel like you're sweating all the time. But you do become chronically dehydrated. In this situation, anybody who's in a dehydrated state for long periods of time, your sympathetic tone has to basically increase to overtake that problem. Okay? So it becomes very important in this kind of environment to do that. Okay? Now, what actually regulates your arterial blood pressure is two things. One is your brain and your central nervous system, which is in this case, when you talk about sympathetics, you're talking about the thoracic-lumbar area, which is located in the spinal cord. Okay, but still, overall regulation to a certain degree has to do with the brain's perfusion. Okay? What the brain is constantly trying to do in its senses is motion. Okay? And when it senses that kind of motion, it senses a drop in perfusion to the brain. It tries to increase that by basically constricting you, as well as increasing your cardiac output. Okay? So the main mechanisms of control of blood pressure are going to be in your heart, okay, and your systemic arterioles. That's what's going to try to maintain your enough tone to keep your blood pressure up so you get adequate brain perfusion. Regulation can be put as immediate or long-term. Okay? Most of what you deal with every day, which is like get up in the morning, come to school, get up from your table, that's immediate control mechanisms. Okay? Something that as soon as you change your position, alters your vascular tone, has to be very rapid. And to do that, you're looking at the neural mechanism to do that. So the autonomic nervous system is the most important component for immediate control. Long-term control, on the other hand, tends to be hormonally based. Okay? And what you're looking at is a posterior pituitary responsible for antidiuretic hormone is a big component of it. The other ones that are, of course, responsible for is the renin-angiotensin system, which also controls aldosterone, which is part of the adrenal medulla. Okay, so you're looking at multiple systems in place to try to maintain your long-term vascular tone as well as your long-term volume status. Okay? So you got to think about those two things, tonicity and overall effects on your volume. Okay? Now, in addition to that, when the organs that are involved for long-term are the kidney and the GI tract. Okay? The GI tract, of course, is a system that is an uptake all the fluids, and the kidneys are the long-term, sort of short-term, not the long-term maintenance of your volume status, which we'll talk about pretty much in next semester. So let's talk about short-term regulation of arterial blood pressure tone. These are the kind of things that you're going to be doing pretty much under anesthesia. When you put somebody to sleep with an anesthetic, what you're basically going to do to a certain degree is depress their sympathetic nervous system. Okay? All the agents that we give depress the central nervous system and depress the sympathetic nervous system to a degree. Most people that are volume resuscitated, okay, do not respond poorly to most of our anesthetics. It's usually lack of volume that's being a big problem for us. Okay? If you have a patient that's in a traumatic injury, when we talk about trauma in the third semester and coexisting, we'll go over how narcotics are not maybe the wisest choice. Okay? Narcotics have a significant suppression of the sympathetic nervous system as well, because what they do is not so much they drop blood pressure, but they basically tell the body, hey, you're not really in a trauma situation. You don't need to vasoconstrict extremely so because you're comfortable. Okay? So the narcotic is not beneficial in that kind of situation when you're severely dehydrated or severely, from hemorrhagic status. Now, how your blood pressures are regulated continuously is by measuring a baroreceptor reflex. Okay? These baroreceptors are found in several places. One of the major ones is located in your carotid body, which is the main artery going to your brain. Now, that kind of makes sense. Okay? You want to have it not in the brain, but you want to have it before the brain. If it was in the brain, it would be already too late to start making changes. So the body tries to make the sensor out here in your neck, and as a consequence, one of the things that we encounter every once in a while is when we do a surgical procedure in that area. Okay? What kind of surgical procedure do we do with the carotids? Right, carotid endarterectomies. We actually do quite a bit of those. Okay? And if you do one side, it's not a big deal. Okay? The other side takes over and it's fine. But if you do both sides, okay, what can happen is you can destroy both of the afferent nerve endings, and then the brain doesn't have a really good system in place to monitor its perfusion. Okay? And actually sometimes you will see that the patients come out hypotensive like crazy and bradycardic after a bilateral carotid endarterectomy. They're not responding appropriately, and you have to put them on dopamine for several days. Now what ends up happening in that situation, the body has a backup system, and the backup system is located in the aortic arch. Okay, so when that happens, it just takes maybe 2 or 3 days for the body to sort of switch over, and it uses the arterial baroreceptors as its main control mechanism to the brain, which means that that person is much more at risk for developing a problem called syncope, which means they're going to go unconscious much more easily. If they get up too quick, they get dizzy and they fall back down. So it's not as good mechanism. But your overall, it's a stretch receptor. What it's doing is it's constantly monitoring the degree of stretch, and that's what it wants. It wants a certain degree of stretch, which means that's how much pulsation pressure is getting there. It doesn't measure blood pressure exactly. In other words, it doesn't have a manometer sitting there and saying, okay, what is the pressure? Instead, it measures how much the artery is being stretched. If you increase blood flow to the artery, what happens to the actual artery diameter? It increases, okay? Which then would actually give a negative feedback mechanism to say, hey, slow down the heart rate and blood pressure and cardiac output. Okay, so it's a sort of a constant. If the stretch gets on the other way, where it's less stretch, that means, hey, increase my cardiac output. Okay, there's not enough blood flow getting to my brain. So it's actually simply a mechanical stretch receptor is a nerve that works there. Now, the carotid baroreceptor is very efficient. It can be knocked out as an afferent using local anesthetic, and when the surgeon's working in that area, sometimes he won't want any degree of vasospasm or very rapid changes in blood pressure when he's yanking on it, because that can cause a stretch receptor response. It can cause almost like a vagal response if you pull on it too hard. because it senses the body will then believe, even though it's not really a pressure, it's being stretched mechanically, it believes that the blood pressure is rocketing upwards, so you get a severe bradycardia and a hypotension. So what the surgeons most of the time tend to do for us is they inject local anesthetic right around the carotid bulb, and it shuts it off. Okay? Now these sensor receptors, or the arterial baroreceptors, are the aortic baroreceptors and the carotid baroreceptors. Okay? Like I said, they're mechanical receptors. They're more the stretch, the more action potential is generated. But the actual signal that's sent to the brain is basically inhibitory. It senses an absolute stretch, and it also senses rate of stretch, which is also important. What you're looking at here is the overall mechanism. The arterial baroreceptor is located here. That's your receptor. So depending on which portion, the aortic arch or the carotids, it sends an afferent, which is going back to the brain. Okay? It goes to the medullary area, which is the medulla oblongata, which is the lowest portion of the brainstem, which then sends multiple fibers to the vagus as well as to your sympathetics. Mostly the sympathetics we're talking about, but there is also a vagal component if you overstretch it to try to slow down the heart. The green arrows indicate an increase in signal to the cord, in this case to the actual sympathetic tone, and that causes the systemic organs to vasoconstrict in the arterioles. And it also is a cardiac accelerator fibers between T1 through T4 to increase as well. So let's give you an example. Okay? What happens when you stand up? When you stand up, what happens to your carotid baroreceptors is they have a slight decrease in amount of stretch. Okay? It doesn't increase the stretch, it decreases the stretch. Okay? That your body is going to try to maintain that tone at all cost. Okay? What happens then is that the signal goes to your medulla oblongata. The medulla oblongata then says look, I'm not getting enough perfusion. It sends out sympathetic discharge, okay, to the spinal cord, okay, and it causes vasoconstriction of your blood vessels, and it also causes an increase in heart rate, okay, by increasing sympathetic output from the T1 through T4 cardiac accelerator fibers, okay, which is your cardiac output, and all of a sudden your blood pressure stays stable. Now your body is actually anticipatory, okay? If it knows that you're going to get up, it already begins to do this already without you even realizing it, okay? If you train all the time to run, if you check your pulse before you think that you're going to go running, and then you say to yourself, well, I'm going to go running in about half an hour. Just check your pulse in 10 minutes. You'll be amazed how fast your heart rate is already bucking up, okay? It's already increasing its heart rate and increasing its cardiac output, getting you prepared to go running. Okay, so there is a certain, overall cortical control, but the medulla can work this along with even brain injury. If, on the other hand, you have a situation where you flip yourself upside down, okay, where you're basically put in a position where you have a tremendous increase in blood flow to your carotids, then you get overstretch. And what happens is that the sympathetics don't get activated. Instead, what gets activated is the parasympathetics. It's not that you get venodilation at that point, because you don't. The sympathetic tone is not increased, but instead the heart rate begins to slow down. Okay? So you may actually get a bradycardia in the situation, a more vagal kind of symptoms when you get that kind of response. Okay? Now, this arterial baroreceptor pathway has a central integration method, which is a medullary component. Okay? The efferents leave for both sympathetics and parasympathetic fibers, which is important. It does have this autoregulatory mechanism in place. The effect on the baroreceptor activity is it inhibits the activity of spinal sympathetic excitatory tracts if it's being positively activated. Okay? Stimulates the activity of spinal sympathetic inhibitory tracts, and eventually stimulates the activity of the parasympathetics, which is what I was talking about when your blood pressure rises rapidly going towards the brain. Now, the actual efferent pathways, make sure that you know that you have two types. You have the sympathetics and the parasympathetics. Okay? These are your major ones that control your heart rate and your contractility. Remember also that cardiac parasympathetics do not affect ventricular contractility at all. Okay, it's only the cardiac sympathetics that has this ability to alter the contractility of the ventricle. The parasympathetics have contractility effectors on the atrium, but not on the ventricle. What you're expected to know for exams is this kind of table. Okay, you have to start knowing these guys because eventually you have to sort of know this in clinical. Okay, the main neurotransmitter that's occurring pretty much from all your preganglionics is acetylcholine. Okay, so it doesn't matter if it's sympathetics or parasympathetics. The first neurotransmitter is acetylcholine. Postganglionic for the parasympathetics is acetylcholine. On the other hand, the postganglionics for sympathetics are norepinephrine, except when you're talking about sweat glands, which are still acetylcholine receptors. Okay? The main receptors are, don't worry about this, I'm not going to argue about this, but just leave these out. Just know that the actual preganglionics and the acetylcholine receptors in the postganglionics for the parasympathetics are sodium channel kind of proteins. Okay, so when you cause the acetylcholine, you cause a depolarization effect on the cell. On the other hand, your sympathetics, they work on G-coupled proteins. Okay, so they're G-coupled proteins, receptor coupling. Some of the muscarinic receptors, which we talk about as well, have some degree of G-coupled proteins. The muscle is also ligand-gated ion channels, but these guys are both, and they can be found both. The lengthwise of parasympathetics is that they're long, which means that it has much more rapid control, versus sympathetics preganglionic are short with a long demyelinated fiber that's postganglionic. So it's more indirect, and it also has the effect of having to cause more of a diffuse effect with the sympathetics. Okay? The myelinated fibers are not present in the postganglionic nerves. Make sure you remember that. And the location for sympathetics is located in the thoracolumbar area of the spine, versus the actual parasympathetics, of course, located in the cranial nerves. And we just went that. Okay. The actual effector organs that are going to be regulated by these immediate effects are going to be the heart and the peripheral blood vessels, okay, which we just showed you. The arterioles are basically the most important part of the ones the peripheral blood vessels are controlled by. And we talked about that last week in Chapter 8. Okay, so make sure that you see where the green's going, the arterioles. Make sure that, do not state that the aorta is getting controlled by sympathetic tone. It is not. That's a conductance vessel. Okay? If it's the major portions of the aorta or the major arteries coming off the aorta, like the brachiocephalic or the subclavian artery, all those are not regulated by sympathetic tone. It's the arterioles beyond that that really are regulated by the sympathetic tone. Okay? The conductance vessels do not have that effect. And then, of course, the heart rate, how it's being affected by this volume changes that you see. Now, you actually have the arterial baroreceptor reflex. It's a continuously operating control system. It's a negative feedback system. Make sure you note that. It's not a positive feedback, it's a negative feedback system. Okay? It tries to maintain a steady mean arterial pressure. Okay? And what it basically is sensing is stretch in the carotid bodies. Okay? Now what you see here is that when you see a decreased mean arterial pressure, let's do it at clinical. Let's make it a clinical scenario instead. Let's say you're putting somebody to sleep. Okay? And when you begin to put them under general anesthesia, what you tend to see is you see a vasodilation to take place. Most of vasodilation occurs from the agents is venodilation. So that you have an increase in capacitance vessels. So the veins and venules begin to dilate more so than the arteries. Okay? So you tend to get drops in preload and the blood pressure begins to fall. The body's response to that, it depends on how much you suppress it. But if you have a healthy individual that has a very intact sympathetic drive, what will happen in that situation is that this decreased baroreceptor will discharge and will actually go to the central medullary cardiovascular center and tell it basically, I'm not getting enough perfusion to the brain. So you'll see an increase in sympathetic activity and you see a decreased parasympathetic activity, which kind of makes sense. You don't want the heart rate to slow down from increased parasympathetic activity. You want it to sort of get out of the way so the sympathetics can take over. This is a seesaw. Okay? Sympathetics kick in more and parasympathetics begin to shut down. Okay? Now, as you're putting somebody to sleep, okay, and if you're giving way too much drug or you've given them a lot of narcotic pre-op, okay, this kind of reflex is very much slowed down. Okay, it doesn't mean it's obliterated. It just means that it's very slowed down. And sometimes if you slow it down too much, then you'll get too much hypotension before the person really begins to respond. Okay? What you'll see is when you see an increase in sympathetic tone is that you'll get an increase in arterial tone, you'll get also an increase in venous tone, and you also get an increase in cardiac contractility and an increase in heart rate. Okay, those are the major effects. So heart-wise, it increases contractility, heart rate, and blood vessels, it increases the sympathetic tone, and it causes an increase in arterial and venous tone. Okay? Now from there, here's what the effects, and this is what's called the cascade event. Okay? If you increase the arterial tone, that increases vasoconstriction. Okay? It increases your total peripheral resistance, and that it leads to an increase in your mean arterial pressure. Okay? If you're looking at you get decreased capillary pressure, increased transcapillary fluid reabsorption, increased blood volume is then returned, which then increases your total peripheral venous pressure, which then leads to an increase in central venous pressure, an increased stroke volume, and eventually leads to an increase in cardiac output. Okay? The only downside to this, an inhibitory effect, is that if you increase contractility too much, what happens to central venous pressure? We talked about this before. If CVP could be going up, if the volume is going up, or CVP could also be going up if contractility falls off. On the other hand, if CVP is going up, it could be from volume, but it also, CVP is going down, it could be from decrease in volume, but also could be due to an increase in contractility, which is what you're seeing in this situation. Okay? The other thing which is not denoted very well in this is total peripheral resistance is not a good thing for the heart. Okay? What happens to increases in afterload on the heart? What's the effectiveness on the stroke volume? It goes down. Okay? So that's one of the things. The body's got to compensate. Okay? It tries to make both ends work together. And that's really the crux of this. I want you to sort of understand that. Your body has to maintain tone while still getting the pump to work. If you don't get the pump to work and tone's going up, pump starts losing its ability. And that you may still have a blood pressure, but you don't have any perfusion. Okay, and that'll kill you just as fast. Okay, you need to maintain both. Examples of this would be like a pheochromocytoma. Clinical situation where you get a very, very high release of norepinephrine by a tumor that's similar to like an adrenal medullary tumor. And when it releases that, it causes the heart rate not to increase proportionally, and you get intense vasoconstriction. And you may, if you don't treat it appropriately, let's say if you give that person a beta blocker by mistake to drive the blood pressure down, you can actually cause the heart to stop. Okay, so it's not the drug of choice to give in that situation. Now what I'm going to do for your exam is this. I have to get you to memorize. I will have boxes like this, and then I'll ask you, tell me what this box should be. Okay? And so this drawing will come back, and I'll ask you to basically put in what the little box means in each one. So I really want you to memorize it. This is one of the few that I really want you to memorize. Other cardiovascular reflexes and responses all affect the medullary cardiovascular center, all other than the baroreceptor system. Okay, so you have, they basically alter the set point, and the reflexes can be found from the receptors in the heart and lungs. Okay, if you stretch the heart, it causes a decrease in sympathetic tone. If you unstretch the heart, you increase the sympathetic tone. So in other words, what's telling you is that once the heart begins to fill, the heart should be able to contract appropriately and shouldn't be okay. If on the other hand you start dropping the volume in the heart, you will get an increase in sympathetic tone, which is usually a traumatic injury. You're losing a lot of blood, and that's why sympathetic tone has to kick in. Now, does this hold true when we talk about congestive heart failure next semester? And the answer is no, not necessarily. So you'll have to relearn it at that point. But right now, just understand the normal reflexes. The normal reflex is when the heart begins to fill appropriately, as long as it's not in failure, okay, usually the sympathetic tone begins to decrease. Okay, which means it vasodilates, which then lets the volume drop back down again. Okay? Now, there's also things like, besides baroreceptors, which regulate your blood flow to your brain, there's other more sensitive indicators of the quality of perfusion to the brain. Okay? These are chemoreceptors. Okay? Chemoreceptors are basically sensing the quality of the perfusion to the brain. Okay? What they're sensing is the levels of oxygen and the levels of CO2. Oxygen, of course, is the necessary delivery of let's see how to put it properly. It's not a nutrient. Okay, if somebody asks you on that on a test, is oxygen a nutrient? The answer is no. Okay, it's really not. Okay, a nutrient is something that you can break down and use as energy. Okay, what oxygen is for is basically it's a final electron acceptor to produce ATP. So it's not really a nutrient. Okay, it's an essential need that your body has, but it's not considered a nutrient. Okay, so that's one of the brain must maintain a certain degree of PaO2 all the time. Okay, if it doesn't, it'll starve for lack of oxygen, and as a consequence, lack of ATP, and the person will die. On the other hand, CO2 is a sensor of metabolic waste products. Okay, it's the engine of life to produce heat and CO2 and water. Okay, so one of the byproducts will tell you how much perfusion. If you lack perfusion in the brain, what will happen is CO2s will begin to decline. So the brain is set up to basically try to wash it out. So if you see an elevation in CO2, the brain will immediately try to increase perfusion to the brain to try to wash it out of the system. Okay? The same thing, does not hold true very much, is that PaO2, as long as it's above 60, the brain doesn't really care anymore. As long as it maintains its minimum. Once O2 drops below 60, some books will say 50, the inflection point usually is around 60, and the maximum inflection begins to occur at 50. Okay, so right between 50 and 60, then perfusion begins to increase dramatically to the brain. So you don't want to do that if you have an elevated intracranial pressure. Okay? Now, the receptors that actually sense these things, some of them actually sense it directly, and others sense it indirectly. Okay? If you're looking at it from the sense, the arterial chemoreceptors, they're found in the carotid bodies and the aortic arch. They're sensing oxygen loads. Of course, there's not much CO2 coming from that area, so it's usually not that important. The central chemoreceptors, on the other hand, are indirectly monitoring CO2. What are they really monitoring? They're monitoring pH. They're monitoring hydrogen ion concentrations, which is really the crux of it. Most students have a little bit of a hard time understanding that initially. There's a very interesting study that was done in the 1960s, and what they did was they took a catheter and put it inside a CSF around the brainstem of an animal. Okay? And then through that catheter, they began to inject very low doses of hydrogen ions. Okay? So a little bit of a acidic solution went into the CSF. And what they noticed that the animal began to do was begin to ventilate very rapidly. And perfusion also increased to the brain. So the brain vasodilated, okay, just like if somebody were to receive a lot of CO2. Okay? And what eventually ended up happening is the CO2 went to zero. The animal hyperventilated himself to a CO2 level of 0 to get rid of it all. Okay? Because it was sensing hydrogen ions. Now, why does that work that way? Is because when you take CO2 and it reaches the brain, okay, it converts into H2CO3, which then converts into hydrogen ions plus bicarbonate. So the carbonic acid converts into hydrogen ions and bicarbonate. And the hydrogen ion is what the brain actually senses. So that's really if anybody asks you what is the direct way your body monitors, okay, it's not CO2, it's really hydrogen ions. If they tell you what is indirectly being monitored, and the answer is CO2, sorry. Okay, so the central chemoreceptors very tightly control your CO2. Okay. The Cushing's reflex can occur when you have a chemoreceptor reflex, which increases mean arterial pressure to maintain adequate cerebral perfusion in the presence of elevated ICP. Sometimes you'll read about that. We'll talk about that later on in some more detail. Now, reflexes also occur not only in the centrally wise, but there's also peripheral receptors and reflexes, including in the exercising skeletal muscle. Okay? We do think that if there's other kinds of hormonal effects, when the skeletal muscle begins to kick in, it starts increasing tachycardia, increases mean arterial pressure. One of the reasons to warm up is to start causing the heart rate to increase and increase the metabolic redistribution of perfusion from the internal organs to the skeletal muscles. There's also a dive reflex, which can be useful at times. Dive reflex directs blood to the brain and heart, causes significant peripheral vasoconstriction and bradycardia. Okay, and this is a very nice thing you can use sometimes if you have somebody in atrial fib and you don't have medications readily available, but you have ice. You can put ice on somebody's face, and you can induce what's called a diving reflex. Ice and ice water on somebody's face can cause severe bradycardia, which in this case, if you're in atrial fib and rapid atrial fib, you can actually slow them down and break them out of atrial fib. It actually works pretty well. Okay? The danger of course, of the dive reflex is if you have any kind of heart conditions and you jump into icy water, you can go severely vagal and you can drown as a consequence to it. Cardiovascular associated with motion, of course, is also important. Different situations will cause different effects in the heart as a consequence, so that can't be, people sort of blow this off, and you can't. When our job, you have to talk to patients. Okay, when a patient comes in and sees you, okay, they're very much in high anxiety. If you come in and tell them, hey, how you doing today? My name is so-and-so, and I'm a student. I'm going to put you to sleep. You're my dog lab 101. That's equivalent to what you just said to the guy. Okay? Now, he's going to be pretty upset. His heart rate's going to go going about 150 miles an hour. He's going to be going like, I don't want you to put me to sleep. You're just a student. What the hell do you know? Okay? So the answer really is you present yourself appropriately and professionally. You say, how you doing today? My name is so-and-so. I'm a registered nurse. I worked in ICU for several years. I'm learning to become a nurse anesthetist. I got Dr. Nolan here with me, or my other CRNA that's with me, and we're all working together with you as a team. Which one is different? Student versus registered nurse, ICU experience, that's what you really are. I mean, you're not coming off the street. Okay? So, but it's a very different, the emotional component. The other thing is, how nervous are you? Okay? If you walk in and you're completely flush red and you're sort of like shuffling your feet like, oh, this is going to be a bad case, it doesn't bring much in concern to the patient. They're going to make him hyper anxious. And emotional components are actually very important. Okay? You'll see significant tachycardia, significant hypertension in patients that normally are not hypertensive. Okay? If you see that, don't blow it off. Okay? It's called white coat syndrome. Okay? Don't think of it as basically benign. It is not. Okay? White coat syndrome can become a big problem for us because that usually indicates to you that that person has a tremendously higher sympathetic tone than is expected. And if that person's been very anxious all night and has not been able to sleep all night and is coming in really nervous, that person has been hypertensive all night and now is coming into in a dehydrated state. So So they're more likely to cardiovascular collapse on you in induction. Okay, and that's what is, you got to sort of pay attention. Now, what's more effective in sedating or making a patient more calm? Versed or you talking to the patient? You just think Versed? I see some people saying Versed. Talk to the patient. Talking to the patient is actually more effective than Versed. Now, do we still give Versed? Yeah, we do get Versed. I mean, everybody gets Versed. Okay? And some people just get too much Versed, and then you get all their little life stories, and we have to become like priests. Some of the stuff that you hear, like, oh my goodness, like, I don't really want to know that. Thank you. Okay? So, just realize that sometimes you get more than you ask for. Okay? The central command, which is the central nervous system, has significant control mechanisms in place. The emotional component is laden upon it, yes, but the sympathetic tone can also become a very important part. If you work in combat areas, you'll notice that young men will be hypertensive, okay? And they'll actually be sympathetically mediated, very high levels for the first 6 months into combat. Once they're in combat for almost 6 months, most men or women that are in combat will start getting adrenal suppression. And that's worrisome, okay? Because they don't heal as well, okay? This is what we call the burnout stage, when people becoming they can't fight effectively anymore. But also when they get injured after that time period, they're more likely not to do well because their cortisol levels begin to become depleted. That person has actually been in combat for such a long time that their actual adrenal gland is actually atrophying, okay? What you see initially when these people go into combat is the adrenal gland almost increases by double its size. Just imagine that. Okay? That means you get double the amount of sympathetic discharge than you normally would. That's why when you hear these people and you ask them about what's it like, and they say, well, I can hear the grass moving. Okay, they're sympathetically already hyper excited. Okay, so any little sound that would mean nothing to you would mean something extremely bad to them. My dad was like that. He was a post-Korean veteran, and you would never wake him up unless you touched his toes. Okay, if you work in a VA hospital, you got to be careful. Okay, you got it when you come up to the veterans, you touch them on the toes and tell them, hey, I'm here. You wake them up in the morning. Never grab them in the chest or grab them in the arms because they'll be up out of the bed attacking you. Okay, I've seen it happen. The first day I was a resident. I was a medical student. I went to the VA hospital, and I already knew all this stuff because I've been around the military almost all my life. So I came up to the first veteran and just tapped him on the foot, and he woke up fine, no problems. And my buddy, didn't know any better. Comes up to the guy, hey, wake up. And the guy was on him and was choking him instantaneously. And I'm going I said, hey, calm down. You're here, and they stop. But it's that hyper, and that's 20 years after combat. It doesn't go away, okay? And that's what's called post-traumatic stress disorder that you see quite often. You also will see reflexes to pain, which we tend to see. There's two kinds of pain, which is somatic and visceral, or what's called superficial or deep, depending on which book you read. Somatic pain or superficial pain is sympathetically driven. Visceral pain, on the other hand, is parasympathetically driven. And it's, as a consequence, causes a vasovagal reaction. If you understand that, that'll make it a lot easier in your career. Okay? Let's say you're doing your case. Okay? One of the things that I teach students when we start to do the anesthetic is that we always are trying to determine how asleep the patient is and how responsive they are to overall stimulus. Okay? So one of the things that you want to do is you want to see what your anesthetic depth is. You check on your anesthetic gas levels and stuff. And then you watch when the surgeon makes his incision. If he makes his cut, you should see no response in heart rate or blood pressure for at least 30 seconds. Okay? That's how much suppression of the sympathetic nervous system you've done. If somebody put a knife to you and you were in dead sleep, you'd be awake in a second. Your heart rate would be up to 140. It would be cranking already. It would be that fast, okay? Even under deep sleep. Under general anesthesia, on the other hand, you can put a knife to somebody's skin and see no effect for 30 to 40 seconds. And that's good. That's what you want to see. If, on the other hand, as soon as the surgeon puts the knife on the patient's skin, the heart rate goes up. What does that mean? You're too light. You don't have the guy deep enough. Okay? You just haven't given enough. Okay? Up it up. Okay? If on the other hand you see 40 seconds later, no effect at all, then it's like, whoa, I've overdosed. Okay? So where do you think most students are at? Blood pressure 70s. That's normal, right? No. Okay, got to back off a little bit, okay? So you got to know where you need to be, okay? Okay? Now, if you are light, and again, this is where students get lost. They see this rapid increase in heart rate, okay? And then the surgeon gets deeper, okay? And he pulls on the intestinal tract or the peritoneum. And then the blood pressure drops like a rock, okay? So what do the students do right away? They lighten up the anesthetic. That's the worst thing to do. Okay? Now, do you have to support the blood pressure at that point? Absolutely, because they just went vagal on you. Okay? You may have to give atropine, or you may have to give something like ephedrine to boost the heart rate back up. Okay? But really what it's indicating to you is that your anesthetic is inadequate in its depth. Okay? Because you've caused the vasovagal response, the afferents, to get all the way to the brain and come all the way back to, and that's what you don't want. Okay, so usually most people that are getting vasovagal are too light on the anesthetic. But you got to remember one thing. Once you get vasovagal, you got to tell one thing to the surgeon. Stop. Tell him to stop. Tell him to let go of the intestine for a minute. Because if he keeps pulling on the intestine, the heart rate's going to go to 0. Okay? So you can't increase your depth of anesthetic if you have no pulse. Okay? So tell the guy to stop, okay, and he looks at you like, oh, come on, you're slowing me down, And the answer is, you're right, you're slowing me down. So increase your anesthetic depth, okay, add a little bit of narcotic if you need to. Usually narcotic's not going to help you. It may actually cause more bradycardia to occur as well. So you may consider something like a little bit more Diprivan at that point to get them a little deeper, okay. So just enough to shut down some of the system a little bit, okay. But most of us will switch over to the anesthetic vaporized agent and increase that agent to try to suppress the vasovagal response. Okay? The other vasovagal reaction that also occurs is what's called the oculomotor response. If somebody grabs your eye and yanks on it, you can cause a severe vagal reaction and cause almost asystole. And I've seen people get asystole from just pulling on the eye. So if you're doing eye cases and you're thinking, oh, this is boring, I don't have to do anything. I don't even have to have drawing up my drugs. Yeah, sure enough. When you don't think anything's going to happen, that's when all of a sudden your blood pressure is 0 and you have no heart rate because the surgeon yanked on the eye and now you got a heart rate of 0. Okay? Not good. You don't want to be there. So make sure you're always ready for stuff like that, just in case. Usually it means that when you get an oculomotor cardiac reflex, it means that the surgeon's local anesthetic didn't work properly, and he's getting that response still. Okay? There's also temperature regulation reflexes. These are feedback mechanisms at their skin that increases cardiac output and increases delivery to different portions. In summary, you have a feedback mechanism to maintain your set point. That's your arterial baroreceptor. It raises the set point by response to exercise, sense of danger, cerebral ischemic response. If you have intracranial increases in pressure, which is your Cushing's reflex, it increases your drive of sympathetic activity and decreases parasympathetic activity. If you see a decreased central venous pressure, which is the cardiopulmonary baroreceptors, and your cutaneous pain will cause that effect as well. On the other hand, if you get a lower set point and you get an increase in parasympathetic activity, as a vasovagal syncopal episode, deep pain, or from increased venous pressure where you get too much activity from too much venous return, that's very rare that you ever see that. Even if you put somebody in deep Schonellenberg, you hardly ever see that because the capacitance vessels are very nicely to set more volume. So the only time you ever see that is if somebody is vasoconstricted intensely for some reason, and then you flip them upside down and you get that kind of effect. Now, as for long-term regulation, this is where I'm going to go next. I'll give you guys a 15-minute break, and then we'll come back to it. And then we'll talk about cardiac valves after that.